You can start now.
Yeah,
Thank you. Thank you.
Dr.
Good.
Prashant.
Yes,
Yeah.
madam. I'll start. Good evening, doctors. On behalf of HITRO, I, Dr. Prashant, welcome you to this experience sharing program on managing PPH. HITRO Healthcare Doctors, as you know, has got 25 years of excellence with 36 state-of-art manufacturing facilities. We have got 300 plus products in portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FTFs in the world. We have Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties and pioneering in quality and innovation. Today's program, an experience sharing program on managing PPH, case studies from Rebel Room. We have got Honorable Speaker Dr. Tanusree Gupta with us. Welcome, Madam. Dr. Tanusree Gupta is Director and Senior Consultant Obstetric and Gynec at Udyan Healthcare Hospital, at Udyan Healthcare Private Limited, Secretary of Association of Private Gynecologists of Lucknow, with 33 years of experience. Madam has got a field of interest in high risk pregnancies, endoscopic surgeries, and infertility. Dr. Gupta is member of FOXI, IFS, PCO Society of India, Indian Menopausal Society, to name a few. Academic activities, Madam has done research work on morbidity and mortality in eclampsia, speaker at various forums, organizing secretary in workshops for UA Foxy 2017 Lucknow, organizing secretary for workshop UA Gynec IHE 2018, local convener for workshop AICOG 2020 for improving obstetric skill, and writer for this obstetric skills AICOG 2020. Over to you, Dr. Gupta. I'll stop sharing.
Yeah, good evening to everyone who has logged in, and to the team of HITRO. Thank you, Dr. Prashant, for that wonderful and elaborate introduction. So today I think we'll be talking a little bit about carbetocin, the wonder drug, and then we'll be discussing about few cases which are real cases to deal with, and we can see the advantages and whatever little bit disadvantages of this molecule. So may I now start sharing my slides?
Yes,
Hello?
madam, you can.
Yeah.
Yes, you can. Yeah.
Yeah. So are the slides visible to you all?
Yes, madam.
Okay.
You
So
can put them yeah, it's better.
Yeah. So why we need to discuss PPH? So we all know that postpartum hemorrhage is a daunting event. Now, how do we define PPH? PPH is a loss of at least 500 ml blood following vaginal delivery, or maybe 1 liter following a cesarean section. PPH is common and can occur even in women who are not at risk, and you all will agree that where least expected, we find PPH there too. And in most of the high risk cases, we do anticipate PPH, and really it is a daunting effect. So, and the maternal mortality contribution of PPH to maternal mortality rate is very high. So we need to discuss PPH, and this is quite a preventable thing. So if we are prepared beforehand, if we know that which are the high risk cases, what drugs to be used, and how can we prevent that I think to much extent the maternal mortality rate, which is quite high in developing countries like India, we can prevent PPH to some extent. So we are always in search of newer molecules which will act in a better way, and that too to contract the uterus, because in PPH also atonic PPH is the most commonest type of PPH we come across. So postpartum hemorrhage, it is unfortunate yet common, and we can see that leading cause of maternal mortality accounting for 35% of all the maternal deaths. Now the MMR, or the maternal mortality rate in developing countries, was 240 per 1 lakh live births compared to 16 in the developed countries. So you can see the difference here. And if we talk about India, the last data that we are seeing is it is 540 per 1 lakh live births. And 38% of the maternal deaths are due to PPH, which is quite a significant percentage of the maternal deaths attributable to PPH. 25.7% of global deaths take place in India, and two-thirds of these are attributed to PPH. So this is the scenario in today's uh, today's world in India, and that is the reason we need to discuss PPH and how to prevent that. So if we're now coming to the etiology of the PPH, we can remember the four T's: tone, thrombin, trauma, and tissue. Tone is the uterine tone, that is after the second stage is over, that is after the delivery of the baby, and once the placenta is delivered, the uterus should be contracted well. Should be tonically contracted, it should give that cricket ball like appearance. But when the uterus is flabby and the uterus is not contracted, it is atonic, it can lead to PPH. Coming to thrombin, this includes the coagulopathies. It can be because of the deficiency of any of the clotting factors, a decrease in the platelet factors, and many times, patients of PIH, like the patient who are going into health syndrome or the patient who are going into DIC, they can also have this deficiency, and this can lead to PPH. The next common thing is trauma. If we see that the uterus is well contracted, but still the patient is bleeding and the PPH is there, then we need to look for injury or to the birth canal, or even rupture or inversion of the uterus and lacerations in the vagina, whether there are hematoma formations, or during cesarean section, we can see for the extension of the uterine angles or formation of hematoma in the broad ligaments and all. Tissue, that is, if there is any retention of placenta or clots or abnormal placental tissue in the cavity, then that should be explored and removed, either digitally or maybe with the help of a sponge forceps. Now, coming to the clinical findings in PPH, we know that for a blood loss of 500 to 1 liter, that is 10 to 15% of the total blood volume, the body compensates for that. So maybe there is no change in the blood pressure, the patient is fine, only little bit of tachycardia, dizziness, or maybe palpitations are there. But according to the blood loss, like if it is somewhere between 1 to 1.5 liters, then there will be slight fall in the blood pressure. The patient will be tachycardia will be there. The patient will be sweating. There can be weakness. And then if the blood loss is more than 1.5 to 2 liters, then there will be a marked fall in the BP. Systolic will be somewhere less than 90 mm. Patient will be restless. Pallor will be there, and because the renal perfusion is decreased, the patient can have oliguria also. And in severe PPH, where the blood loss is more than 2 to 3 liters, that is 35 to 45% of the blood volume, there will be a profound fall in the BP. Patient can collapse, air hunger will be there, and the kidneys also can have, patient can have acute renal failure, and there can be anuria also. So measuring the urine output and maintaining the vitals and monitoring them becomes very, very important in these type of patients. Now, how do we diagnose postpartum hemorrhage? Now, a word before we go in for the diagnosis is that we do not focus ourselves to diagnosis only. We have to manage the patient side by side and then keep on seeing things to reach to a diagnosis also. So, first of all, we can ask someone to see the patient's vitals, whether her pulse, BP, SpO2, and everything is monitored. We can see for the urine output. If needed, we can put a catheter and see the urine output and see that the renal functions are maintained. And then we start seeing clinically that what is the cause of the PPH. Like we can palpate the uterus per abdominally and see whether it is well contracted. If not, then we reach to a diagnosis of atonic PPH and we try to medically manage it and give uterine massage also. Massage can be on per abdominal examination also by massaging the fundus of the uterus, or if needed, we can go in for a bimanual massage also. So massage and the medicines. If still the uterus is not contracted, then we can go for the intrauterine balloon therapy. But most of the times, I will say like in 80% of the times, the PPH is normally covered by use of the uterotonics and the uterine massage. So if not, then we can go in for the ballooning part also. So last is the surgical part, like if it is not responding to anything, then we can of course go in for hysterectomy. And especially in cases where we are doing a C-section and the uterus is not responding to any uterotonic or anything, then we can think of going in for a hysterectomy if possible in these type of patients. And then examination at the time of hemorrhage. Now we have to assess the entire genital tract for lacerations, hematomas, or sign of uterine rupture. We have to also look for uterine inversion, especially in cases of vaginal delivery. And we need to explore the uterus for the retained placental tissues. And then, if needed, we can do a bedside ultrasound to check if the uterus is well contracted or if there is any presence of any tissue or anything in the uterus. And side by side, we have to send the blood samples for the laboratory assessment in the form of complete blood count, hematocrit, platelets, and coagulation studies for assessment of serum fibrinogen. So, how do we approach towards a patient of PPH? So, we have almost discussed many things out of this. So, we need to see what is the cause of the PPH and then try to treat that. If it is uterine atony, we start with the uterine massage, we can give the uterotonics, and then, if still not controlled, we can go for the balloon, intrauterine balloon therapy. If still not controlled by all these, then we can think of the surgical interventions to treat the PPH. Now, tears and trauma, we need to see whole of the birth canal. That is, we need to see right from the vagina, the cervix, the vault. And in cases of C-section, we need to look for hematomas for any extension of the uterine angles and treat accordingly, repair these things. If needed, we can take the help of ultrasound and do a quick ultrasound, bedside ultrasound to see for any causes. If there are retained tissues, we need to take them out either manually or we can use very gently, we can use a sponge forceps. So, and in cases of coagulopathy, if the reason is coagulopathy, then we need to transfuse the blood components or the clotting factors, whatsoever the reason is, we need to arrange those and transfuse that. Rationale for the development of carbetocin in new heat stable formulation, because oxytocin and this ergotalcaloids, like that is the methyl ergometrin, these need to be refrigerated to avoid the degradation. So now with the invent of this heat stable carbetocin, it is very easy to have this in our labor rooms or in any small setup or maybe in the government setups also. And since this does not need refrigeration, and we can use this for the prevention of PPH. Now, previous formulations of carbetocin will need to be stored between 2 to 8 degrees centigrade, but the heat stable one has a shelf life of 24 months and at 30 degrees centigrade and at 75% humidity. So, resource poor, resource poor countries who do not always have cold chain transport and storage capabilities, it is rather a boon for these type of setups. Use of uterotonics. What do we have in our armamentarium? We have oxytocin, we have carbetocin, we have ergometrin, we have symptometrin, which is a combination of ergometrin and oxytocin. And of course, we have carboprost and we have misoprostol. So all these things are there, and most of us, I think, we are practicing the active management of the third stage of labor, where we are using a uterotonic prophylactically, maybe at the time of crowning of the baby's head or at the time of delivery of the anterior shoulder, or if not, then we can give it after the delivery of the placenta or at the end of the second stage of labor. These utrotonics, they can be used for prevention and for the active management of the stage of labor, and also as a therapeutic agent for the management of PPH. So what this carbetocin is, this is a next generation drug for PPH. Now, several modifications were done to the oxytocin molecule or oxytocin structure, and then this drug carbetocin, which has a prolonged half-life and it reduces the enzymatic degradation, this was manufactured. This is a synthetic long-acting analog of oxytocin used for the prevention of postpartum hemorrhage due to uterine atony. One vial of 1 ml contains 100 microgram of carbetocin. Now, coming to the clinical evidences, the efficacy and safety of carbetocin versus oxytocin. Now, oxytocin is a drug which we have been using for pretty long. I think most of us obstetricians have been using it for years together, since our PG days and before that. So we consider oxytocin to be a very safe drug, very easy to use drug. So now when we compare carbetocin to oxytocin, especially in the prevention of PPH, this was found to be non-inferior to oxytocin, and that was done through the WHO champion trial. The advantage of carbetocin over oxytocin is when we use oxytocin, maybe some of us can mostly use 10 units. At times, if needed, we can even go up to 20 units in IV infusion. But then a continuous infusion of oxytocin is needed because this has got a shorter half-life. But carbetocin, we need to give a single dose and the action is prolonged and very quick. So the uterine tone is maintained in a better way and repeated infusions are not needed. So this is what we have just discussed now, that oxytocin has a half-life of 1 to 6 minutes, whereas carbetocin has a half-life of 40 minutes. So when given IV, this action is quite prolonged and of up to almost 120 minutes, that is 2 hours, and at times nothing more is required to maintain the uterine tone. Whereas in case of oxytocin, maybe after one infusion, a second or third infusion is also needed to maintain the uterine tone. So carbetocin is non-inferior to oxytocin. This was proved at the WHO champion trial. And patients enrolled were 30,000 women across 10 countries. And the proportion of women with blood loss of at least 500 ml or the use of additional utrotonic agent, that was the primary outcome. And also women with blood loss of more than 1 liter. This was seen in these trials. So we can see that this table shows that this is non-inferior to oxytocin. Let's see what the Cochrane review says. Cochrane says these are the review data from 11 studies involving 2,635 women. And this shows that for women who undergo a C-section, carbetocin resulted in a statistically significant reduction in the need for therapeutic utrotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer adverse effects. Now, what the guideline recommendations are, if we see that all over the world, the guideline recognize the benefits of carbetocin for preventing uterine atony, including WHO, including SOGC from Canada, the France Council for Obstetric and Gynecology, the FIGO, then Germany, New Zealand. So all these groups, they recommend the use of carbetocin for the prevention of PPH. So now, Dr. Prashant and my audience, we come to some real case discussions, and we
Yes,
can
madam.
have We can have interesting cases from any of our viewers also who need to say something or discuss something. I think this should be an interactive session because I think many of us are now using carbetocin as the first line drug for prevention of PPH. So this was a very simple case of normal delivery. This was a gravida 2 para 1 with moderate PIH. At 38 weeks, we decided to induce her. So for cervical priming, we use Cerviprime, and then subsequently the patient was induced with oxytocin. And after 6 hours, patient delivered vaginally, female baby weighing 3 kg, and patient was given 100 microgram of carbetocin after delivery of the fetus. So the uterus was well contracted after the delivery. There was no PPH, and post-operative also the patient and the baby were stable. So this is one question which often comes to our mind, that if we are inducing the patient with oxytocin, can carbetocin be used? I think you will agree with me that yes, we can use carbetocin in such patients also. Because whatever amount of oxytocin we are using for induction also, that is very small in amount. So in these type of patient, carbetocin is not contraindicated. Now, most commonly used, carbetocin is most commonly used in most of the patients of the C-section. So the second case is a case of a second gravida para 1 with previous LSCS, 38 weeks twin pregnancy. Now, twin pregnancy is another factor where the incidence of PPH can be more, and especially due to atony. So both the fetuses were presenting as breech. Patient had mild hydramnios, which is common with twin pregnancy. And after delivering the second baby, we had given her carbetocin, and both the placentas were delivered. Uterus was well contracted, no PPH, no uneventful postoperative period, no secondary PPH, and the mothers and baby were discharged on day 4 from the hospital. So, just one thing. I think one case is not shown in this somehow, that slide. Where has that slide gone? So now the third case, I think the slide is not visible here. Before this, there was one more slide. So that was a patient of high risk pregnancy. That was a IVF treated patient, 38 years old patient, and she had everything. She had twin pregnancy, she had GDM, she had PIH. So all the risk factors were there, and at around about 37 weeks, we tried, we did her elective C-section. Before that, for her GDM, she was managed on diet plus insulin. For PIH, she was on labetalol and Nicardia also. And then for her, this thing, her twin pregnancy and her Doppler and everything was normal. But since she had GDM and PIH, we decided to do her elective C-section at 37 weeks, and she was taken for elective cesarean section. And there also we had used carbetocin intravenously, and everything, the outcome was good. There was no PPA, the patient was stable, both the babies were good, and both the babies and the mother were discharged from the hospital on day 4. So now, Dr. Prashant, coming to the panel questions.
Yes, madam. Madam, thank you so much. It was lovely, hearing your case studies and your experience. I'm sure the audience is benefiting out of this.
Yeah,
What is the
but one
patient
thing,
profile? Well, one
yeah,
question, madam, I've always wanted. See, we
yeah,
know that from your experience, I have realized that carbetocin works very well in prevention of PPH. Madam, what about
yes.
secondary PPH? How effective is carbetocin even in secondary PPH? Or have you encountered cases, have you seen cases of secondary PPH?
We have seen patients of secondary PPH, but the incidence is very less. And
Okay.
we have not used carbetocin in those type of patients, to be very
Of
frank.
course, yes.
If there is second, because if you see in your own, in the slide
Yeah,
presentations
yeah, yeah, yeah.
also, it is not for the management of PPH.
No, no, no. This
So
is for
when there is
prophylaxis.
secondary PPH, the most thing is that we like to see if we can, then we explore the uterine cavity, because many a times it is some part of retained placenta or something which is causing
Okay.
the secondary PPH. Or at times it can be coagulopathies also, or at times there can be a decrease in the platelet counts. So if it is because of atony, then I think we need to go in for prostudin, that is the carboprost.
Okay.
That
Yeah,
acts very
prostaglandins.
well because we don't have time to lose, When we are managing
PPH, yes.
PPH, you have to be very quick.
I mean, yes, yes. I mean, I remember in my time, madam, we had only oxytocin and methergine. And a PPH
Yeah,
case occurs, the whole hospital, I was in JJ Hospital, Mumbai. The whole
yeah.
hospital would be in that, you know how it is.
Yes,
So
it
keep
happened in
OT
our
ready.
times
Yes,
also.
yes,
It
yes,
happened in our times also. So then came the active management and everything.
yes, yes,
And
yes, yes,
see, where carbetocin, one thing with carbetocin is in many a patient, not many a patient, in few of our patients,
yes,
while
yes.
especially doing the C-section, when the anesthetist is giving the carbetocin, maybe in few of the patient, the desired effect is not there. I'll not
Yes, it
say
will
that
always
it
be there. Yes,
it is not a PPH, but then the uterus is not that well contracted, what we expect
contracted.
it to be.
Yes.
So in those type of patient, we do use prostadine or maybe,
Prostaglandins.
yeah, prostaglandin or maybe misoprostol we put
Prostrol. Yes,
intravaginaly after the procedure
correct,
is over so
correct,
that
correct.
secondary PPH is not there. Because
Yeah,
maybe,
very,
once you finish off the
yes,
cesarean and the uterus is not well contracted, you shift the patient to the ward and then suddenly you see the patient in
yes.
secondary PPH. So you have to
Very
be little
honestly, we
bit
will,
careful.
yes, very honestly, we lose everything that we have at this point of that point
Yes,
of time.
yes. So we
Yes,
have to be extra careful that
yes,
when the
correct,
uterus is contracted, it is well contracted. That is the word.
correct.
Not only contracted, well contracted.
A season ball, like, yes.
Yes. So
So,
what
what is
we
the
used to
patient
read
profile?
quoted. Yes. So now coming to the
Can,
panel questions, what is the patient profile where doctors can anticipate PPH? Now let me just tell you that there are certain patient profiles where we can anticipate PPH, but then it can happen to any patient. Where we do not
absolutely.
anticipate, then too. To be very frank, I had a very VIP type of patient and sterility treated patient, and we planned her elective seizure. And let me tell you, we were not anticipating PPH, but the uterus didn't contract. We gave her
I
everything,
know.
all the uterotonics, kept massaging the uterus, and finally, after quite a long time, we could make the uterus contract. And there were no risk factor, absolutely normal pregnancy. So, patient profile is, I mean, you can expect PPH in any patient, but
Yes,
then too,
yes.
there are several risk factors like a grand multipara, any elderly primigravida, then patients of PIH, then patient
Correct,
of
correct.
multiple pregnancies, then patient having hydramnios, and patient with prolonged labors, patient in obstructed labors, patient with a history of APH. So these patient and any patient who has a history of PPH in her previous
Previous
delivery. So
patient with
these are the
fibroids,
patient
yes.
profiles, yes, and
Yes,
patient with fibroids, yes, very
fibroids.
true. Multiple fibroids, and especially if there are more so in the submucous type of fibroids
Submucous,
are there,
yes.
then. So in these type of patients, we can anticipate PPH.
Okay.
Should we go to the next question?
Yeah, yeah, yeah. Next question. Or you want
Okay.
me to run this question, or you'll run these questions?
Yeah.
Otherwise, you can
So,
stop. I will run these questions. Or you
okay.
can run whatever way
So,
you want. Whatever way you want.
okay, I'll keep running this because I
Okay,
think,
okay. Chalega. We can finish it.
okay. So, in which patients would you prefer to use carbetocin over oxytocin for prevention of PPH? Now, the first indication I think should be that where we are anticipating PPH. So,
Correct.
the patient who are identified as high risk for PPH, in those type of patient, we can use carbetocin over oxytocin, and also in our elective seizure or emergency seizure patients. So these are the patients where we will definitely like to use
Prefer
carbetocin.
carbetocin.
Yes.
Yes. The next one.
Now,
Yes.
can we use carbetocin in case of retained placenta?
Of course, after removal of placenta, of course.
Yeah, so in retained placenta, like in many of the cases, if you remember, Dr. Prashant, we used to give that through the umbilical vein, we used to give
Yeah, yeah,
oxytocin
yeah,
to
yeah.
remove the retained
Oxytocin.
placenta. Now,
Hmm.
we have not tried anything of that sort with carbetocin, but
Carbetocin.
yes, once the retained placenta is removed manually, then I think we can give the patient
Yeah.
carbetocin. But many a
Correct.
times in these type of patient, we do give prostaglandins because
Correct.
prostaglandins make the uterus contract, very quick, and the contraction is really good. So this is
And
little bit debatable, I'll
yeah.
say, that
Yeah,
whether
yeah.
we
And that will help in expansion of placenta also. No, if it contracts very hard,
yes, yes.
expansion will be easy.
So,
Expansion will
because
be easy.
in my practice, whenever I am doing a MRP for a retained placenta, I'll normally use prostaglandin more.
Correct, correct, correct.
So
That's
that is the
important, but
thing.
individual experience is more important because in our practice there is always individual
Yes,
experience we
yes.
respect most.
So we in those type of patient, we do use after the MRP is done, use prostaglandin. Can we use our
RH negative.
carbetocin in RH negative? Yes, we can, because the main fear in RH negative patient is the feto-maternal hemorrhage, which can lead to
Yes, 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 yes.
sensitization. But then
Correct.
we are covering these mothers during antenatal period and also in the postpartum period with anti-D. So I think
Anti-D.
we need not worry about the feto-maternal hemorrhage, and if there is any chance of PPS, then we should of course use carbetocin in these type of patients.
Correct.
Now, can a doctor
You have
use
answered
carbetocin?
this, madam. Yes, you have answered this already.
We
Into the
have
first
answered
slide.
this.
Yes, yes, yes.
And in which cases would you prefer IV route over IM route? So this is like in, I think, like in our practice, we are maintaining a IV line for every patient, be it for a normal delivery or for a
Correct.
C-section, because you never know when any obstetric emergency is going to come. So
Absolutely.
so since we are using a IV route, normally we like to give it IV. So in the labor room, our staff, the nursing staff, they give the carbetocin IV. And when it is in the OT, normally my anesthetist, he does the same. But if the IV route is not available, like you can see
Oh,
in the peripheries and all, so they can use the IM route also.
I am
It
good.
the only thing is it takes a little bit more time for the molecule to come into its action, but then the action is sustained. So
Longer.
using it
Yes.
IM route is not a contraindication. We can use it depending on what facilities we have and what is the method that we are using.
In fact, that's one of the advantage over oxytocin that it can be used IM also.
Yes, yes. If patient is not responding adequately with carbetocin, what additional utrotonics do you use? Now here we have several things like the prostaglandin, that is the carbipros, the
Prostaglandins. Yes.
misoprostol, yeah, the prostaglandins. And of course, I am little bit reluctant in using the methylargometrin because many a times this can cause acute respiratory distress syndrome. I am seeing that myself. So I'm little, and then in the patients of PIH or those having little bit higher BP,
Blood pressure. Yeah, yeah,
and
yeah.
yeah, it can further rise the BP, and at times patient can throw a fit and go into eclampsia because of this. So we have to be little bit careful in using the methylargometrin preparations. So in these type of patient, prostaglandin derivatives, whether injectable or the intravaginal ones, they are, I think, a safer option. What are the advantages of carbetocin over other utrotonics? That it is very safe to use, easy to store, especially the heat stable one, easy to use, and with minimal of the side effects. So I think these are the advantages that the carbetocin
Correct.
has over other
Other
utrotonics.
uterine.
Should carbetocin be kept as reserve drug or it should be used as a first line? What do you say?
I will say first line.
Yes, you will say carbetocin should be the first line drug. Of course, I do agree with you, but then little bit of cost factor and all those
Yes,
things are there.
yes.
So either of oxytocin or carbetocin, both can be kept as the first line because
First line.
most of the obstetricians, or you can say the nurses who are into
Yeah.
deliveries and all, they are more familiar with oxytocin because they have
It's
been
our
using
textbook
it
brand,
for.
madam. Yes.
Yeah, that is a textbook
Yes.
brand, and all the
Textbook brand.
Manyata and
Yes.
all, they
Yes.
promote the use of oxytocin as the active
Oxytocin.
in the active management of the third stage of labor. So it will take some time for
Correct.
carbetocin to be
Correct.
used as the first line drug,
First line.
but certainly this can be used as a first line drug.
First line. Yes.
What is the
And the
role
role
of
of
an
gynecology,
anesthetist?
yes,
Yes, so this is very important. I'll say that yes, anesthetist plays a very, very vital role, because once we are operating and or maybe we are delivering, and if there is PPH, we are busy finding the cause of the PPH, massaging the uterus, giving instructions to the team. So the person who is at the head end, that is the anesthetist, he is the best person to choose the
to take
drug.
over. Yes,
Yes, of
yes,
course
yes,
they do
yes.
ask us कि मैम क्या
Yeah,
दे
correct,
दे, whether we should give prostaglandin or whether you should get carbetocin or whatsoever. So certainly the role of anesthetist is very, very vital in
correct.
choosing a drug for prevention of PPH, and they know the patient better, because since they
Hmm.
are at the head end and they are giving the anesthesia, they know all the indication and
Hemodynamic parameters. Yes,
and
yes.
hemodynamic parameters in that
Correct,
particular patient. So,
correct,
and
correct, correct,
they are the one who is going to manage the patient during that time. So,
correct.
it is, I mean, their role is very vital, no question about that. So, now coming to
Finally,
the conclusion, that carbetocin is a very well tolerated, very good drug. The storage facilities need not be there. I mean, the cold chain maintenance is not there. The only thing is, at times, there can be little bit of adverse effect with the use of carbetocin, and especially if it is given very fast IV, then patient at times, they can complain of nausea, little bit of dizziness,
okay,
a
okay,
little bit of flushing. So what we are doing nowadays, Dr. Prashant, is we are giving it in 100 ml of normal saline.
okay.
We are not giving it IV, because initially when it was launched, we did try to give it direct IV, but
Bolus.
then that slight hypotension was there, initial slight
Mhm.
hypotension, flushing, dizziness,
Correct.
nausea. So then our anesthetist, we decided that we'll give this in 100 ml of normal saline.
100 ml of saline.
So yeah, so that was very good, and the adverse effect were decreased to a great extent.
Large extent. Yes.
Yes, large extent. So now the second thing is that you have to be prepared with the other utrotonics like the prostaglandin derivatives, because
Absolutely.
in few number of cases, if we do not get the desired effect with carbetocin, then of
Correct, correct,
course
correct.
you need not wait, and you can give the second utrotonic.
It's an
So
emergency
that,
then.
yes, yes. So you need to be prepared for that. So I
Madam, thank
think,
you so much. It was a lovely session, madam. A lot of insights I'm sure the doctors would have got. One thing you'll agree with me, madam, this PPH is a topic, wonderful topic for discussion, but we hope no
yes.
doctor gets it ever and
But
expect the
everyone
unexpected
gets it.
is.
Everyone
Yeah,
gets it.
yeah.
That is the thing.
I know.
Because, I said like when we are least expecting, like there is no risk
Correct.
factor. We
Expect the
are simply,
unexpected, madam.
yes.
That is the whole thing in
So
gynecology.
PPH is one thing that it is not 100% predictable.
Expect the unexpected.
Yes.
Thank you so much. Thank you. Thanks all the doctors for taking time and participating in this wonderful session. I'm sure everyone would have benefited. Thanks marketing team, IT team. Thanks Sanjana. Thanks Bivas. And thank you all. Signing off, madam. Wish you a very pleasant evening. Thank you.
Thank you. Thank you so
You
much.
can sign off,
Thanks.
madam. Thank you.
Okay. Okay.
Thank you. Thanks Sanjana. Thanks
Madam,
Bivas.
thank you so much. She's okay.
Madam is logged off.
Oh, yeah, yeah.
Thank you. Thank you.
Okay. Thank you, Sanjana. Thank you, sir.